We're marking the 40th anniversary of the first MMWR of HIV, which is June 5th, 81, as you know. And so there's two questions. One, how did HIV prepare us to fight the COVID battle? And two, how has COVID in turn affected HIV?
You know, when you shut down the country, Ben, as you well know, services, be they making it available for people at risk to get tested, and if positive to get treated, and if negative but still at risk to get into a PrEP program, that got significantly disrupted because of COVID-19.
So it's fair to say that you would have hoped we'd be a little further along at this point in time had it not been for the COVID epidemic.
Yeah, I think you could fairly, honestly say that. And I hope as we get the COVID-19 under control, which, as you well know, we're starting right now to see a significant diminution of cases as we get more and more people vaccinated, that we can, play a bit of catch up with HIV and get the ship righted again.
Can you tell me some of the ways that you've observed how HIV has helped you fight COVID better?
Take, for example, Dr. Barney Graham at the Vaccine Research Center, very rapidly using techniques that originated with HIV, namely working on the trimer of the HIV envelope. They used those structure-based vaccine design to determine the right conformation of the prefusion spike protein, which was not a good immunogen because it was unstable. So they used the same mutations to stabilize the molecule that we used in HIV, now one of the most spectacularly successful vaccines, utilizing technologies that were based in the HIV vaccine network. Number two, dating back decades, we established a very extensive clinical trial networks that were readily used and pivoted to be the testing network to test the vaccines. So right away, what was done from a pure scientific and clinical research standpoint with HIV made it that much more easy and adaptable and pivotable for SARS-CoV-2.
How about just in your own work, how has HIV prepared you for this moment?
We've seen two global outbreaks that rank historically among, the top 6 to a dozen outbreaks in the history of civilization. When you're dealing with HIV, with the 77 million people having been infected and over 35 million deaths, and COVID-19, which is the worst respiratory pandemic that we've experienced in 102 years, all of which are in our lifetime, which is really, unfortunate for us, but, striking in that. So getting involved in an emerging outbreak from the very beginning. I mean, this is the 40th anniversary of the recognition of a new disease. For me personally, it's a very important landmark because this coming summer, 40 years ago, I completely changed the direction of my research and my career because I became fascinated by what I saw was an emerging domestic and global pandemic that most people downplayed as a fluke that was going nowhere. And because of my being convinced, given the nature of it, even before we knew what its name was, or certainly what its etiologic agent was, that we would have over the years and now over the decades, an evolving outbreak, because outbreaks don't reveal to you what they ultimately will be on day one. It's an evolution. So what I learned from HIV was very helpful in my appreciating how COVID-19 evolved. I spent multiple years of my life from 1981 through the early 1990s taking care of people, almost all of whom died. Now, all of my patients, most of them are leading normal lives. So that was an evolution that took several years. Right now, things are compressed into a relatively brief, explosive period of time with COVID-19. but we still had that evolution of knowledge over a period of months to a year. So I think that's the kind of thing where I learned from my experience
Right.
with HIV that these things are evolving all the time.
What are some ways that COVID will ultimately benefit HIV science, do you imagine?
The extraordinary success of the vaccine platform technologies, particularly mRNA,
Right.
is already now being pursued by HIV vaccinologists to see if we were not dealing necessarily with the right platform.
Right.
That if you can get mRNA to code for the right conformation
Right.
of the envelope trimer, the same way we got the mRNA to code for the absolutely correct conformation, a stable conformation of the spike protein, I think potentially this is very exciting for HIV.
I mean, you said that you were hoping at least that the phase 3, the HIV vaccine trials will be maybe 50 to 60% effective. Is that still a good hope for you? And do you think then you would want to roll them out globally at that point and maybe hope for any better vaccine down the line?
You know, it's very interesting that you mentioned that, Ben, because when we were talking about what we might expect with the vaccines for COVID-19, I would have been absolutely delighted with a 65 to 70% effective vaccine. And when we found out there was 94 to 95, it was, my God, beyond our best dreams. So, you know, deep down, there's a part of me that says, you know, yeah, I'll accept the 55, 60% effective HIV vaccine when now that I saw what happened with COVID-19, I'm grasping at some hope that we might be pleasantly surprised.
High standards. You're basically half your life you've been working on HIV. You're hitting a big milestone. Any thoughts of what that brings to mind at this very historic moment where we're fighting another epidemic on top of it?
Yeah, I mean, the thought is a sobering thought that the human species is beset with emerging pathogens that can be absolutely devastating and disruptive to everything currently the way COVID-19 is to the planet, which to me emphasizes the importance of preparedness for pandemics and responsiveness to pandemics. You know, there's two elements of it. There's the preparation and there's the response. The one thing that will stick out for me, and I'll tell it to anybody who's willing to listen, is that the one success story in our COVID-19 experience is the fruits of the investment in basic and clinical biomedical research, because no one in their wildest dreams would have predicted that literally within 11 months from the time we recognized the brand new virus, that we would have a vaccine that was highly efficacious, that ultimately proved highly effective in the real world, would be put into people's arms in 11 months. It would have been inconceivable. In fact, when I even said back in January, when they said, how long do you think this will be? I said, oh, I don't know, maybe 12 to 18 months, I said. And it turned out to be 11 months, you know, even quicker than I would have thought. And I think the speed of that was related to the fact that we were testing it in the middle of a very robust outbreak. So you were getting efficacy signals pretty quickly. So that was part of the speed of it.
And you think that indeed HIV played a role in the speed of that response?
Oh, absolutely. I mean, I'll argue that forcibly with anybody, because not only of the science, but of the infrastructure to allow you to test 30,000 people in one trial, 44,000 people in another trial, 40,000 people in the third trial. That's what we were doing for years with HIV.
Let's talk about the social determinants of health and racial disparities. That's something that we're very familiar with in the HIV world. How did that knowledge of how those inequities tend to play out prepare you?
They played out so similarly, and that's the thing I bring up. The disparities in our country that relate to social determinants of health that put people in positions that are not of their choice. We know African Americans comprise 13% of the population. they have 44% of the new infections. 65% of them are men who have sex with men. 75% of them are young. You know, that's not racially determined. That's the situation that they find themselves in. Then you get to COVID-19. By the nature of the jobs that brown and black people have, that put them out into society in essential jobs, they have a higher likelihood of getting infected.
Yeah.
But the thing that's so painful is that the social determinants of health that date back to their birth make them have a higher incidence of the comorbidities that dictate that they will have a more serious outcome than those comparable demographic that don't have these higher incidents. So none of those, Ben, are racially determined.
Right. They're not related to the color of their skin.
They are all determined by social determinants of health. Hopefully, as I've said, that this outbreak has shown a bright light on these disparities, that we could really make a societal commitment to do whatever we can to get rid of them.
Let's compare activism and community engagement and all the changes that happened, say with you working with ACTAP, with Mark Harrington et al. During the early 90s. And that really changed the way that people with certain conditions fight for their own needs when it comes to how research is designed and carried out. So can you tell me a bit about how those changes in that time really prepared us to have community and activist engagement in the research process with COVID?
Oh, there's no doubt about it. I mean, we proved with the activism of HIV that getting the community involved is clearly essential to getting equity. And that's the reason why it's a different kind of a community, a somewhat different dynamics. But that's the reason why we're outreaching right now into brown and black communities. I mean, it's remarkable the amount of time that I and some of my colleagues spend engaging in black churches, in black organizations, black and brown caucuses in the Congress, to get people energized, to sort of make sure there is equity in every aspect, equity in clinical trials and equity in the distribution of vaccines once they've proven to be safe and effective.
What do we know about increased risks of negative COVID outcomes for people with HIV?
There have been a couple of studies, Ben, that have been done, and it looks like, all of the things being considered, that for an otherwise well-controlled person living with HIV, it's the comorbidities that put them at a greater risk for a poor outcome. So if you have somebody who's 40 years old, has got an undetectable viral load, a CD4 count of 700, and doing well, the likelihood that they, because of their underlying disease that may or may not have been treated early enough, they likely have underlying comorbidities. But if they don't have comorbidities, they're not more at risk at all of a worse outcome. That's different than the uncontrolled viremia and a CD4 count of 4, that kind of thing that you still see. Those individuals clearly are at higher risk of a serious outcome.